So let's talk about rapid sequence intubation today, or RSI. This is just going to be the basics of what we need to know. So let's just jump right in. What is RSI? RSI, rapid sequence intubation. This is an advanced procedure because we're utilizing, well, A, we're going to be intubating our patient. That's an advanced procedure 1. But B, we're going to be utilizing medications to paralyze our patient so that we can intubate them. Our immediate concern with our patient is to have a patent airway and adequate oxygenation and ventilation. And so by utilizing RSI, we're gonna get those things. This is also going to help us to manage some of the harder to manage airways. Does anybody have any ideas on what these hard to manage airways could be? So it could be your burn patients, patients who are awake with respiratory issues, patients that have those inhalation injuries, patients that have a gag reflex but need an airway, patients with trismus, so they're clenched down. When you think about it, it's essentially any patient who is awake but needs to have a protected and secured airway. Okay, so how do we obtain a secure airway? Well, the only way to obtain a secure airway is to utilize an ET tube. So, what is a secure airway? The airway is secure when the trachea is isolated from the esophagus with the ability to maintain the delivered pressures in the lungs from ventilation. The bulb at the end of that ET tube secures the trachea from gastric contents. That's good. So now we're preventing aspiration and we're maximizing oxygenation. Those are all good things. So what are our goals of RSI? Everybody think for a minute. What are some of the goals of RSI? What are we wanting to accomplish? Well, A, we're wanting to establish a secure protected airway. B, we want to protect our airway protect our patient from aspiration. And then C, we want to be able to establish a modality to change ventilator settings if necessary, so that we can optimize or maximize our oxygenation. So let's talk a little bit now about actual airway compromise versus potential airway compromise, okay? And so there's lots of different ones. We're just going to talk about a few. So actual airway compromise is patient's got an altered mental status with the GCS of less than 8. They're apneic. They've got respiratory failure. Some potential airway compromises are patient that's got prolonged severe respiratory distress. So they've been working really hard for a long time. They're getting tired. They're getting exhausted. Or patients with head bleeds or strokes. Patients that have a seizure history. Patients that are confused and combative, and trauma patients. And then another one to think about is your CHF that's refractory to CPAP. So CPAP's not helping, but they need an airway. Your patients that have that potential airway compromise, well, all patients anyway that have actual airway compromise, we need to always have a backup plan, and we need to think ahead. We can't wait until we get in the heat of the moment and plan A doesn't work. We need to have plan B, plan C, and plan D already in the back of our head, ready to go, waiting. Those secondary devices, we need to have those already out, ready to go. We don't want to be right in the middle of something and it fail and we're not ready with our backup plan. So it's always better to be prepared and not need something than to not be prepared and not have it ready. Especially when we talk about RSI, because once we paralyze these patients, use this medication to paralyze them, they are not breathing on their own at this point. We are responsible for everything, okay? And so we don't want to compromise our patient. So that's why we need to think ahead and plan ahead and have that plan and know it ahead of time. Now our next question is to RSI or not to RSI, okay? So what are some of the indications? Well, some of the indications for RSI are actual respiratory failure from any cause or an impending respiratory failure. So sometimes you've got to think ahead and know. The inability or actual inability to protect the airway from any cause. Combativeness secondary to head trauma. Hypoxemia despite our maximal therapy and our maximal efforts. And so we've used every tool in the box at this point, and our patient is still hypoxic. We've got to do something for them, okay? Some contraindications. Predicting that your patient is going to have a difficult airway. It's going to be difficult to manage or difficult to obtain. And we'll talk later about some tools that you can use to help determine this. Is doing this RSI procedure going to delay ED arrival? What does that mean? Is it going to delay ED arrival, or is it going to delay your scene time for something unnecessary? Can it wait until the patient gets to the ED? You've got to ask yourself that. Contraindications to a medication you want to use. It's important to know what medications you have available, what medications you're going to use when you utilize RSI, and know the contraindications so that you know if your patient, if that medication is contraindicated in your patient. If it is, then we can't do it. The ability to manage the airway with less risky procedures. So again, when you think about managing the airway, start with least invasive to most invasive. So can you manage the airway some other way? If you can, then do it that way. Don't automatically jump right to the most invasive procedure. Sometimes you can manage the airway with using your BLS skills, but this is a presentation about RSI. There we go. Does the patient meet the need or the criteria for RSI? So let's talk about some of those things. Is the patient's airway or breathing compromised in any way? Are there any contraindications? Okay, back up. So is the patient's airway or breathing compromised? If it is, then we need to think about RSI. Are there any contraindications? If there's contraindications, we can't RSI. We need to think about our risk and our benefits. Do the benefits outweigh the risk? If the benefit outweighs the risk, then by all means do the RSI procedure. But if the risk outweighs the benefits, then back up, slow your roll. Even if that patient needs to be intubated, is it something that needs to happen immediately, or can it wait until they get to the ED? You've got to think about all of these things, and what's at hand and what's going to be best for your patient, because at the end of the day, we want to do what's best for our patient. So let's talk a little bit about difficult airway. So before jumping right to rapid sequence intubation, we need to think about and evaluate the difficulty of the airway. Because, like I said earlier, once you paralyze that patient, you are completely responsible for their airway. And you need to have a backup plan. Plan B, Plan C, Plan D, Plan E, because you never know what's going to happen, and you need to have that ready. So before we just jump right in, we need to assess how difficult do we think this is going to be. So one of the tools that you can use is the Lemon assessment. So Lemon stands for look, evaluate, Mallampati, obstruction, and neck mobility. So let's start with the L, look. So the first thing that we're going to do is look at our patient's anatomy. Do they have a small mandible, large tongue, short bull neck? Are they obese? All of those things can affect the ease of intubation. Do they have any abnormal facial or neck anatomy or anything like that? So take a look. Look at their teeth. Do they have buck teeth? That can make a difference, okay? Then move to E, which is evaluate. So let's use the 3-3-2 rule. So first one, can the patient fit 3 fingers between their incisors, those incisor teeth? Can we fit 3 fingers? Okay, good. Is the mandible at least 3 fingers from the mentum to the hyoid? Okay, that's good. We want 3 fingers there. And then is the distance between the hyoid and the thyroid 2 fingers? If it is, that's good. So yes to all 3 is good. If not, then know that this intubation can be a little bit difficult. M is Mallampati. Our next slide is going to be all about the Mallampati score, so we'll talk about that in just a minute. Let's jump up to obstruction, or O. So does our patient have lots of secretions? Do they have stridor? Is their voice muffled? Do they have a mask? Is there anything that's causing some type of obstruction? So facial trauma or any kind of facial anomaly. Like I said earlier, do they have extremely bucked teeth? Again, things like that can make a difference. Even obesity will make a difference here. And then we're going to look at the neck mobility and how easy it is to move their neck, because again, we want to think about getting our patient in that optimal position for intubation. That's that sniffing position. So can we move their neck to get them into a good position? So is their C-spine immobilized? That's going to make it a little bit more difficult. Do they have rheumatoid arthritis? Again, just look at the mobility of their neck, and that's going to help to determine if you can get them in the optimal position. Okay. So now let's take a look at the Mallampati score. So the Mallampati score is, again, one of the tools that you can use to help determine how difficult the intubation is going to be. And so if the patient will cooperate, have them sit up, open their mouth, stick out their tongue, and say, ah, okay? We can all do that. Now, when they do that, you want to look into their mouth. Look in the back of their mouth. If you can see the tonsils, the tonsil pillars, the hard and soft palate, and the uvula, if you can see everything nice and clearly, then they're class 1. And so there's not going to be any difficulty there. Class 2, well, really not too much difficulty there either when you've got them opened up. With class 2, you can see the upper half of your tonsil palate, so you can see hard and soft palate. Class 3 is just being able to see that palate, and then class 4, you're only able to see the hard palate. So you can kind of see the progression in class 1, class 2, class 3, class 4, and how it goes from no difficulty to extreme difficulty. So class 1, completely open, you can see everything. You can see the uvula, like I said, the pillars, your hard palate, your soft palate. Class 2, you can still have a pretty good visualization there. Class 3, all you really see is the palate. Class 4, you just see that hard palate. So you know you've got a difficult case in front of you, so severe difficulty. So that's the Mallampati score. And again, these are just tools. So now let's move into the procedure and what are we actually doing. So there's the 6 P's of intubating RSI style, okay? So the first one is prepare. The second one is pre-oxygenate. The third P is pre-treatment. The fourth P is paralyze. The fifth P is placement. And then your 6th P is post-intubation management. So we're going to go through and talk about each one of these in detail because it's essentially the steps of what we're going to be doing. There we go. Okay, so let's start with first, preparation. So first thing we want to do is make sure that we've done a thorough assessment of our patient. And we've looked at their airway and we know that we're good to go there. Second thing is prepare the equipment. Again, you should have already checked out your equipment at this point, but now that you know that you're going to be doing this RSI procedure, you want to make sure to prepare your equipment. Check your laryngoscope, make sure you've got the right blades, make sure your bulb is lighting properly, make sure you've got the appropriate size ET tubes, you've got your stylet, your 10 milliliter syringe, you've got suction ready to go, make sure you have an IV in place because we've got to have some way to give these medications, and then we've got airway backup plans, like I said, plan B, C, D, all the way down to Z if we have to, and have those backup methods in place, ready to go. Don't wait until plan A fails to go dig around looking for plan B. Have it ready to go. And then the last thing on our list is make sure we've got all of our medication drawn up and labeled and ready to go. You don't want to be trying to draw up medication during the middle of the procedure. Have it all drawn and ready to go. Okay, pre-oxygenate. So, pre-oxygenation. This is huge, you all. This is huge, huge, huge. So we're going to spend a little bit of time talking about pre-oxygenation. So the air that we all breathe is about 21% oxygen. It doesn't matter where we're at, it's 21% oxygen. So the remaining 79% is mostly nitrogen. And so if all that nitrogen in our lungs was replaced with oxygen, then we'd have about 5 times the oxygen that we've got right now. And so when we pre-oxygenate our patients, that's exactly what happens. And so that this pre-oxygenation stage is sometimes referred to as the nitrogen washout, because we're washing the nitrogen out of the lungs and we're replacing it with oxygen. Okay, so this 5-fold increase in oxygen in the lungs creates an oxygen reserve that our body can draw on once our patient has been given that paralytic and ceases to breathe. Okay, this is important. So patients that have healthy lungs and they're functioning with an adequate residual capacity, they've got enough reserve from pre-oxygenation to survive for about 8 minutes of this medication-induced apnea without desaturating, without a loss of blood oxygen saturation. So let me stop right there. Are the most of the people that we're happen to use RSI on super healthy? Probably not. So most people aren't going to have that 8-minute reserve, or the people that we're going to be dealing with, the people that we're going to be working on. And so most critically ill or injured patients, they can't tolerate 8 minutes of apnea. I mean, so we've got to think about some things that would decrease oxygen reserve and storage capacity. So elderly patients, they're not going to be able to tolerate that. Obese patients, pregnant patients, patients that have lung disease, it could be acute, chronic, or some combination of both. Patients that've got chest trauma or that have hypoxemia, they're not going to be able to tolerate that 8 minutes. Or patients that have a need for an increased oxygen consumption, they're not going to tolerate that 8 minutes either. So I want you to take a second and think, what are some situations that would cause our bodies to increase our oxygen consumption? Just think for a minute. Think. Okay, so your patient's got a fever, or they're septic. They've got severe pain, or your patient that's in alcohol withdrawal, or your patient that's got cocaine or methamphetamines on board. They're going to go through their oxygen consumption much faster. Patients that are tachycardic, patients that are in shock, and children fall into that role as well. So they're going to have an increased oxygen consumption. So that's something you've got to think about. So now let's talk about, so when you're thinking about all of that, you need to remember that when you push these medications and then you start your process, you have a small window of time, okay? We don't have much time. So we need to be ready to go and sharp with our skills. So how are we going to pre-oxygenate that patient? If they've got a non-rebreather in place, go ahead and throw a nasal cannula on them too. Turn that non-rebreather up to 15 liters. Put the nasal cannula in and flood them with 4 to 6 liters via nasal cannula, because we are trying to completely wash out that nitrogen. If you're bagging the patient with the bag valve mask, again, make sure you've got it turned all the way up. But then also put a nasal cannula in that person and flood them with oxygen through the nasal cannula as well. Excuse me. So the next question is, how long should we pre-oxygenate? Well, a minimum of 60 seconds. But no, it can take up to 3 to even 5 minutes to get this patient at the greatest oxygen reserve possible. That's what we want to make sure they have the most oxygen possible, okay? And so when you're on scene and you're preparing to do this, this is important. I mean, look at your watch, look at the clock, and you're going to have people on scene that are getting antsy because you're just sitting there just pre-oxygenating. You know, you're either bagging them or you've got that non-rebreather on. People start to get antsy, and your firefighters or your partner is like, okay, it's been long enough. No, you need, like I said, at least 60 seconds. But no, hey, 3 minutes, it's okay. You can use that time. Get their oxygen reserve up as high as possible. Give them as much oxygen as possible. So we just want to flood them with oxygen, okay? The next one that we're going to talk about is pre-treatment. So some patients will require some pre-medication before we even get started. So pre-medications are the drug that we're given in the early part of our RSI, because we're anticipating some complications. So for suspected head injuries, you want to give your patients lidocaine. Lidocaine is commonly used in patients that have head injuries because it's going to blunt an increase in intracranial pressure or decrease that response. With your pediatric patients, atropine is the medication you want to think about giving, because succinylcholine is associated with bradycardia in our younger children and patients receiving a second dose of succinylcholine. And so atropine is usually recommended routinely 2 to 3 minutes before the administration of succinylcholine in children less than 6 to 8 because we're trying to reduce that risk of bradycardia. And then we also want to ease anxiety in our patients, and not just patients that are presenting with anxiety, but really you could think about treating anxiety in all patients, okay? And so we could use fentanyl or we could use Ativan. So let's talk about fentanyl. So at routine doses, fentanyl is an excellent analgesic that'll help keep patients comfortable during the procedure. Higher doses, fentanyl is a sympatholytic, so again it will blunt the hypertension, tachycardia, and increased intracranial pressure elevations that's associated with laryngoscopy. And it's reasonable to consider, like I said, to consider giving all patients an analgesic dose just to decrease that anxiety, to keep them calm, to keep their heart rate low. I mean, it's going to help us in the long run, because remember, one of the ways that we increase oxygen consumption was through tachycardia. So we don't want our patients to get tachycardic and worked up, okay? So we want to keep our patients calm. The next part of pre-treatment is the induction. So all patients should be induced for this procedure, especially if their Glasgow Coma score is greater than 3. Essentially everybody, okay? Sorry, lost my train of thought. The purpose of an induction agent is to make our patient unaware during this procedure. So patients that are hemodynamically stable, we can consider giving benzodiazepine. So before we talk about benzodiazepines, hemodynamically stable, what does that mean? They've got a good set of vitals, they've got a good blood pressure, they've got good heart rate, okay? So an example of a benzo that could be available to us is midazolam. So again, this is a benzodiazepine or sedative or hypnotic. The major advantage of this med is the amnesic effects of it. And so the patient's unlikely to remember the procedure, but one of the disadvantages is that the dose that we use for induction is associated with hypotension. So typically benzodiazepines will drop the blood pressure, so they're contraindicated in patients that are hemodynamically compromised already. We don't want to double that. So with our hemodynamically compromised patients, so hemodynamically compromised, what does that mean? Look at all these big words we're using. Low blood pressure, low heart rate, okay? We can think about using things like etomidate. So etomidate is good for inductions because it rarely will cause a drop in blood pressure or pulse. It works fast. And that's good. That's what we're looking for. Some other induction agents that are available to us and that are being used more frequently are ketamine. Ketamine's a dissociative drug, and so like I said, it's being used more and more in EMS and in the critical care setting. One of the advantages of it is that it's got a predictable response. It doesn't really cause that hypotension. It provides the analgesic effects with the sedation. The only bad thing is that there's some patients that it will cause some hypotension and tachycardia in, but not the majority. And then propofol is commonly used for induction as well. One of the reasons that we don't see it used a lot in EMS is because of its profound hypotension effects. So something to think about. Okay. So the next portion that we're coming up, the next P is the paralyzed, okay? So this is a big step. our paralytics or our neuromuscular blocking agents are drugs that temporarily stop the skeletal muscle function without affecting our cardiac muscles or our smooth muscles. Remember, those are the three types of muscles in our bodies, skeletal, cardiac, and smooth. And so these neuromuscular blockers work only on the skeletal muscle. And so before we get into the two specific categories, because there's two specific categories, remember that we're going to paralyze our patient about 15 to 30 seconds after administering the sedative. Then we can go ahead and paralyze our patient. And remember, these things are all happening rapidly in order, okay? So right here we've got this picture of our neuron. So I'm going to kind of explain to you what's happening. So in normal neurotransmission, the neurotransmitter is going to be acetylcholine. And so it's released from the nerve ending into the neuromuscular junction. That's this space right here. So this is our presynaptic neuron and our postsynaptic neuron. So this is the one that's transmitting the signal. This is the one that's receiving the signal over here on this side. And so the release of the nerve of the acetylcholine from the nerve ending to the neuromuscular junction. This is occurring secondary to an action potential along this axon. So things are happening. We're going to talk about what happens here, and then the acetylcholine is released into this neuromuscular junction. So, like I said, the action potential happens, and then you've got the opening of our calcium channels at the nerve terminal. Those are our transporters here. And so the flux of calcium triggers the acetylcholine to go into this neuromuscular junction, and as it diffuses across the gap, it binds to our nicotinic receptors right here, okay? And so on the muscle cell of the opposite side of our neuron terminals right here, these nicotinic receptors, the 2 molecules of acetylcholine are required at each nicotinic receptor in order for our sodium and potassium ions to open. And once that happens, then the muscle membrane is depolarized, and an excitation contraction happens, and then acetylcholine is rapidly moved across, rapidly hydrolyzed by the acetylcholinesterase at that neuromuscular junction, terminating that stimulatory process, and then the muscle membrane repolarizes, and we do it all over again. And so what happens with these paralyzing agents is that they're interfering with this process in the neuromuscular junction. So let's first talk about depolarizing neuromuscular blockers. And so depolarizing neuromuscular blockers mimic the action of acetylcholine by producing that depolarization and acting as a receptor agonist. And so all that acetylcholine is released into that neuromuscular junction, and then it's fast acting. It only lasts about 3 to 5 minutes, but it does cause fasciculations or muscle twitching, okay? And so you'll see that. With non-depolarizing neuromuscular blockers, these are competitive antagonists of acetylcholine. So they're going to do the opposite. They're going to bind to that post-junctional receptors, and it's going to prevent depolarization. And so we're not going to have that one last flood of acetylcholine before the patient is paralyzed. So we won't have the fasciculations. Okay. This again, like our depolarizing neuromuscular blockers, you're non-depolarizing, they're fast acting, but they last 30 to 90 minutes. And like I said, it does not cause the fasciculations because there's not that flood of acetylcholine. So, where are we at? Let's talk about some of the specific agents here, okay? Before we talk about some specific drugs, let me back up for a second. With those non-depolarizing neuromuscular blockers, like I said, they're fast acting, they last 30 to 90 minutes, and then a benefit of our depolarizing neuromuscular blocking agents is that our patient will actually begin breathing faster. but one of the disadvantages is the contraindications. And so we're going to talk about the contraindications of the depolarizing neuromuscular blockers. So, succinylcholine is going to be the first that we're going to talk about. This is a depolarizing neuromuscular blocker. And so we like it because of its fast onset. It's about 45 seconds, and then it's got a short duration, lasts 3 to 5 minutes. Like I said, it's got a host of potential adverse effects that result in a number of contraindications that we've got to consider for all of our patients. And so if your patient has neuromuscular diseases like muscular dystrophies or myopathies or Guillain-Barré syndrome, it's contraindicated. One of the contraindications is knowing that this can exaggerate hyperkalemia, or high potassium can affect our patients drastically. Strokes, Parkinson's disease, tetanus, botulism, rhabdomyolysis, burns greater than 24 to 28 hours old, spinal cord injuries greater than 72 hours old but less than 9 months, prolonged immobility or paralysis, severe infections, and severe trauma. Those are all things that are contraindicated when wanting to use succinylcholine. So, like I said, it's fast acting, lasts only for 3 to 5 minutes, causes those fasciculations, but it's got a lot of contraindications that go along with it, and things to consider when thinking about using them in patients. So on the flip side, we'll talk about the non-depolarizing neuromuscular blockers. They're fast acting, like I said, and last about 30 to 90 minutes. Rocuronium or Zimuron is the most commonly used agent. Its onset is slightly longer than with succinylcholine. It's about 60 seconds. At the recommended intubation doses, it can last 30 minutes or longer. That's at 30 to 90 minutes. It has very few adverse effects, and it can be used for initial and ongoing paralysis, so that's good. Okay. Another one is Vecuronium. It's non-depolarizing. It's common to use after succinylcholine just because the succinylcholine doesn't last that long, so you can back it up with Vec. So Vec is a second or third line agent because of its long onset time. So that's kind of your paralytics in a nutshell. Let's move on and talk about the next one. Placement. So this next P, visualize. We have to visualize the tube passing through the vocal cords. We've got to confirm placement. How do we do that? We listen over our lung fields, listen over the epigastric area, put our capnography on, and note the number at the teeth. And then we want to make sure that we secure our tube. Post-intubation management. So again, make sure our tube is secured. Make sure that we're monitoring our end-tidal CO2. Adjust our ventilatory settings to maintain end-tidal CO2 35 to 45. And make sure that we keep our patient sedated so we can use midazolam, Versed. If we need to, we can keep our patient paralyzed. And that's for patients that are continuing to buck the tube or got movements that inhibits effective ventilations or threatens the stability of our airway. That can't be corrected with sedation. So sedating them sound enough, we can keep them paralyzed, but we've got to make sure that we're managing that airway if our patient is paralyzed. And then pain management. Sometimes we've got to manage our patient's pain. Once we've got them knocked out and controlling their airway, our patient still may be in pain, and we need to manage that pain so that we don't cause their blood pressure to rise, cause their heart rate to rise. So we've got to manage pain as well. Let's see, some pharmacological agents that we use for our side. This slide is just kind of a medication slide in a nutshell. So it talks about our pre-medications, lidocaine, atropine, fentanyl, our induction agents, your Versed, propofol, etomidate, your paralytics. You've got your depolarizing neuromuscular blocker succinylcholine, and then your non-depolarizing neuromuscular blocker Zimuron. Got our choice there. And then some post-intubation medications: Zimuron, Vecuronium, Versed, fentanyl, or morphine for that continued pain management. So before we close this out, I just kind of want to go through the procedure one more time just so that everybody is on the same page. So when we think about the procedure, we know that we've got the 6 P's, so we make sure that we're prepared. Make sure that we pre-oxygenate our patient. Again, it can take a while. Take the time to make sure that your patient is adequately pre-oxygenated. The pre-treatments, give any of those pre-treatment medications if necessary. Then we move to paralyze. And so with our pre-treatment, we give any pre-treatment medications, and then we give our induction medication, and about 30 seconds later we can go ahead and give our paralytic. Then we need to make sure that we place our tube, and then we provide our post-intubation management and go from there. So that was RSI. And if you've got questions, go back and look to your book. You can call me, email me, and we can talk about it. But that's RSI. So again, I hope you enjoyed it, and we will talk soon.